Hello and welcome to the first episode of our new oncology podcast series, Onc Now, with me, your host, Dr. Jonathan Sakia. This series was designed to spotlight the leading experts in all subspecialties of oncology, and today I'm delighted to be joined by a much-loved member of our own EMJ Oncology Editorial Board, Dr. Divyanshu Dua. The good doctor serves as Executive Director, Medical Services at Central Gippsland Health Service in the state of Victoria in Australia, and he's been there since early 2023 in that role. He has additional responsibilities, including serving as Clinical Dean at the Monash Rural Medical School, running a Medical Oncology Clinic weekly, being General Physician on call, and Primary Supervisor for doctors in training and consultants in peer review, as well as for international medical graduates. Divyanshu completed his internship in New Delhi, his senior house officer jobs at St. Peter's in Chertsey and the Lister Hospital in Stevenage, both here in the United Kingdom, of course, and then trained further in Adelaide in Australia, over to London for some advanced oncology training, and then clinical observerships in Ireland and the UK. In addition to his clinical practice, Divyanshu has been actively involved in teaching and research, is an active member in multiple medical professional societies, and has authored peer-reviewed articles in journals internationally. Divyanshu is passionate about innovation in oncology, and he spent his career leading cancer care innovation and integrating business practices and his acumen with clinical expertise to improve patient outcomes. So, given how busy he is, I'm absolutely delighted that he's made the time to join us today. I hope you enjoy our conversation as much as I did, so let's pop over and join the podcast. So, I love origin stories. Tell us about your journey in oncology and into the areas you specialize in and how that shaped your career journey.
Uh, my journey has been quite interesting in the sense that I come from a non health background as in terms of my family. So I think the reason my journey wasn't very oncology specific to begin with, my oncology journey was a passion to change and passion to actually make some changes. My mother died when she was around 12 years of age, and at that point, she died of a disease where they had no cure or not much of clinical research. So that really prompted my career in the sense that my passion to become a clinical researcher and be able to make some change later down the track and to improve healthcare for people. And that's probably has driven me in the last 20-25 years, going through the medical school, learning and doing clinical research. And oncology really transformed in the way as our treatments have changed. It's a science which gives us the opportunity for changing lives of people every day in our clinics, in our clinical trials. We make choices, we make advances so that the next person who's got the disease actually lives a much better life as much possible, and we continue to improve. So I think a journey we started off as a personal challenge is now transformed into something which I think I look forward for the next patient is the changes that I can make as a clinician for the life which was not available for my mother almost 40 years ago.
Yeah, yeah, it's interesting, isn't it? How many of our colleagues have a similar experience? There's a personal experience in their family, and they commit to do something about it. And I don't know if you're familiar with Joseph Campbell's The Hero's Journey, or The Hero with a Thousand Faces, and it's how there are only six stories, I believe. I think it's six stories in literature or in the film business, and this is one of them, isn't it? It's about becoming a hero and trying to challenge this particular enemy. I know that cancer care for older adults is one of your areas of interest, and this area of oncology presents a number of unique challenges. What have you found to be the main differences in treating the older versus younger patients?
I think cancer in older people is very unique for a few reasons. Because as we live older, I mean, we there is a the as we seem older, it just seems to be a common notion that oh, people are older, so they should not get the treatment, or they're older, they're not actually able to handle the treatment. And we should be treating older adults very, very differently. And that's a kind of a biggest challenge that we need to change. We just can't have everybody included in that basket. Yes, there are frail people, there are frail, there are pre-frail, but there are lots of them which are fit as well. So the idea of the older oncology and the challenge is to filter out in the first place whom to treat and whom not to treat. And obviously the concept of quality of life, concept of actually maintaining what they can do is actually quite important. And as our research has actually gone about, we've always said people with old adults, they handle the treatment exactly the same like any other individual. So they're not any different. We just need to screen better. We just need to provide the resources better. We just need to have a better support structure around it. So that's what it makes it unique. We're not doing anything different. And we're just trying to make sure that people are treated equally and given the best choice they can.
One of my teachers at medical school, Divi, said that he was a surgeon, and he said that, and as am I, that we spend our first 5 years learning how to operate, our next 5 years learning when to operate, and the remainder of our career learning when not to operate, and about having a sensible dialogue with our patients, their caregivers, and providing tailored, not only tailored therapy, but tailoring the approach. And I'm sure that's the case for your specialty, yes?
Absolutely. I think it's when we started this journey with the cancer in older adults, the people. I remember the conversation with the patients in a day-to-day clinic was based upon, "Oh, doctor, I'm old, so I don't think so. You got any choices for me?" And that still sits with me in the sense because that's not true. I mean, the choices are there, and our treatments have evolved from chemotherapy in early 2000s to molecular therapy in 2024. So these treatments are minimally toxic. They maintain the quality of life, and there's no reason why we should not offer the treatment. And these are the fit people who pretty much living the life on their own. So I think that's been the biggest change.
Yeah. So I noted from June to October last year, 2023, you managed a staff survey to assess for barriers when discussing advanced care planning with patients. What did you learn and how did you apply that to your clinical practice within your institution?
So obviously advanced care planning is something where we already, I mean, that just falls into my passion for the cancer for the older adults, in the sense that we asking them the question upfront, in the sense that, okay, if you were to be, this is like a planning for the future, asking them what do you feel your medical care should actually look like, who should be involved in your decision making, and what are your wishes essentially. And when I joined the organization which I'm currently in, I was basically, over the last 10 years, the advanced care planning rates on record has been between 10 and 14%. So basically, one in seven is the only person who's ever actually even thought about it or had it in writing a plan to figure out what they want in the future care, which obviously is a quite a bit of concern. Obviously, when they come to the hospital, and if that's not documented, then it might just lead to the care which does not work with their principles. So the first barriers is to figure out, if I'm going to change something, what I need to do, what how do I need to actually work around it. So this survey was basically designed to figure out at our staff, really, what do you think, what's stopping you from having those discussions. So the biggest barrier that I actually came across was, a, the staff was not there was no staff education process which was around this ACP survey, in the sense they were not given any tools how to have the discussion, no script, answer the question, education, etc. And also to finding out, and there was a lot of question about, oh, it's not my job, it has to be a general practitioner's job, or no, it's the specialist job, and oh, I have given the information, patient doesn't come back. So I think the whole process, education, and trying to give the staff the timing, and access to the resources was the biggest learning that we actually got out of the survey. We've actually managed to drop the within the 8 9 months and the changes that we made. We managed to drop the percentage from 14 to 22%.
Okay, wow. So, as a follow-on question, Divi, talk to us about compassionate care for both patients and their loved ones. That I like to say that there's the disease, and then there's the dis-ease, the stress of living, especially with a malignant diagnosis, for the patient and for their loved ones. How they manage that.
So as a medical oncologist, you tend to carry your patient. You what I personally call is an end specialty, where basically you carry them from a diagnosis to their journey. So you are a partner in their journey. So it's compassionate care, in my view, is a patient focused care, where you take to them to a process where, okay, somebody has got a diagnosis of a malignancy, whether it's early stage, late stage, and then your compassion starts from the time you meet them, from the time you give them your compassion in terms of how you phrase your diagnosis, how you actually give them the treatment choices. So you're not. So I think the compassion is giving them the treatment choices not based upon who they are, who they where they came from, basically giving them all treatment choices based upon the best evidence-based treatment, and basically guiding them in the decision making, and actually supporting them whatever choice they make. There are some situations where you feel that as a clinician you can do a lot better and patient should be choosing these choices, but patient may have a different ideas, quality of care, their family, etc., and they may have a different way of thinking about a cancer or disease process. So from my view, is obviously compassion is really working with the patient and coming and be with them in the journey regardless. So in my clinic, I would say to the patient, look, I will support you whatever you choose. These are the options. This is you should be available. You should consider these are the best available choices. But if you decide not to do with the treatment, we will still manage you symptomatically, we will still manage you compassionately, we will still do everything possibly working with you so that you feel empowered that you possibly done with the journey. Because one of the biggest challenges in oncology is living with the guilt. Have I done everything? Have I done everything for my family? Have I not let the family down? So those are the biggest questions which people with cancer really have to face every day. So that's something which nobody should be able to have that. And we try and support them and make the decision process. Compassion is about giving them the time, giving them the space, not making sure in a busy clinic, oh, I'm giving you the diagnosis, you need to make a treatment choice. No, it's about patients. If they're actually not ready, they probably want to speak to the GP, they want to speak to their local doctor, they want to speak to their local church. That's giving them the time to do it is the right thing to do.
Right, absolutely. Well, it is about you nailed it. It's about dialogue, having an open dialogue. And Sir William Osler uh, said many years ago at Johns Hopkins that a good doctor is able, which is obvious, available, which is important, and affable, which is very important. Health care. That's what we're in this for. So, as a follow on question, in addition to your medical qualifications, you also hold a master's in business management. How has business administration, how has your business training influenced your approach to the practice of medicine? I'm noticing a trend. More and more doctors are doing this and, realizing that they can play a role in the delivery of care way beyond prescribing a drug or performing a procedure.
That comes from the conversation. That's come from a long-standing conference that doctors don't make good managers. So I think that's actually the notion. So I think the doing the degree and having those knowledge actually just helps. I'm here to change the notion that doctors can be good managers. Uh, this was a conversation I was having with my CEO this morning, and basically was trying to say, uh, the doctors don't work as a group. So I was trying to explain to him, who has a nursing background, to translate, look, the doctors are not designed to work as a group. They always, from the time from the school to the medical school, you are it. So you need to be in a competitive spirit. You need to be better with B, C, and D to get there. You're not taught, oh, you need to work together to get there. No, the doctors are never taught to work together. So I'm here to make sure that it's about passing the things to the next generations. It's not just doing stuff, it's about able to do it better and planning for the next generations to come. And only way you can actually do is to be involved in the healthcare planning for the next generation and trying to institute changes which are quite passionate. So it's not just the health is passion for me. Health is basically trying to uh, health planning development is actually one of those other sub passions of mine too, which is basically what I'm trying to do. And I think the masters in business just gave me the tools to understand the concept. We all talk about leadership, but there are 8 different types of way you can actually lead, or even more. So there's so many theories behind it. So you just learning those basic concepts helped me understood really what to do. And in medicine school, I mean, the financial management, the operational management, the strategic management, it just gives you those tools where you understand the business. Because as a clinician, I just say, oh, there's just the admin, they just don't support. But if you look on the other side, it's a very different picture. So you now I can see the both sides, from a clinician looking at the admin. Now I'm also got the opinion from the admin looking at a clinician, so I can see the both sides. So it just makes me a much more fairer person that I'm dealing with, and actually makes me less complaining.
Yeah, yeah. You're absolutely right. There is this conviction that we can't possibly manage. We don't have the mindset for it. But I think we better than anyone understand the needs of patients and their families. And I'm constantly confounded when I see administration impose changes on clinical staff that they've not even discussed with clinical staff. One of them was telling senior doctors that they don't need offices, they don't need private offices, that was elitist and an unnecessary waste of space. Well, in my book, a place where you can talk privately to relatives, or take a moment for yourself, frankly, during a stressful day, or talk to a junior colleague and provide some counseling. You need a private space, and it just blows me away. But I want to come on to where you live. You live in Australia, a country I've been very privileged to meet on to travel to on many occasions. Gorgeous place, a fabulous climate, especially up in Queensland. Um, but it comes at a price, a historically high incidence of skin cancers, malignant melanoma. And I recall during one of my first visits, they had launched the Slip, Slap, Slop, and they then added Slide as a campaign. So, first of all, I thought it was brilliant. Educate our listeners as to what Slip, Slap, Slop, Slide means, for those who don't know. And secondly, then launch into a narrative as to where we are with malignant melanoma. What is state of the art in treating this wretched disease, and what's just over the horizon?
That just goes back in the 1980s, 90s, where basically it was Australia just came across as a places where there were beaches and people just sunbathing for a very long time, and then came the concept of a sunscreen. So that was where a public health campaign was, because because skin cancers are quite common. You just basically, it's the education that goes from the primary school to the high schools and colleges, where the education about sunscreening, using about the sun protection strategies, because that's one of those common thing which can stop you from skin cancers. um, when we look at melanoma in Australia, we are the highest incidence of melanoma for a few reasons. A, the sun exposure, the lifestyle, because the good climate makes people go out a lot more, have more sun exposure, lying on the beach, etc. So that probably we have the highest melanoma incidence. It comes at a price, because as you know, melanoma is not just a skin cancer. It can rapidly spread. It is one of those cancers where it's it affects younger people. It's an aggressive disease. It's a quite a difficult disease to manage, and sometimes can be treatment. When I started my training about 15 years ago, we were treating melanomas with chemotherapies, and we just basically said, look, I can't do anything to increase your life. Only thing I can actually do is to make sure that you live longer for a few months. That's the best I can do. Then we've had then we've had immunotherapies, and now we combining immunotherapies, and then targeted therapies came along. So now people with melanomas can expect to live longer. We're now looking at, oh, these people have got no disease now, although we call them a stage 4 or end disease, but they don't have any cancer left behind, and we can't treat them indefinitely. So we are now looking at stopping treatments. Now we've gone ahead and said, look, we probably should give you the treatment earlier, which is just when you had your cancer removed. That would be the time to give you the treatment, not wait until you get a stage 4. And then obviously we've got 3 or 4 important immune targets. We've got targeted therapies, we've got combination therapies. So melanoma is worldwide. And one of the reasons melanoma is exciting is because the representation of the Australian population in melanoma clinical trials is much higher because of our incidence. So all international trial are done in Australia predominantly because they can actually recruit better. So
No.
it's something which I've seen from a point zero in my journey across as an oncologist, and I can see where these people are, and people have done so well, and they can actually living longer, and to see some disease which is actually affects the younger people is quite an amazing. It's actually been a quite amazing journey to be part of.
Yeah. And as I recall, it was slip on a hat, slap on a shirt, slop on sunscreen, and slide on glasses, which they added later as a way to defeat skin cancer. And seek shade. That was it. Seek shade.
Because you
That's
know
the
that you can still have you can have the melanoma behind the eye as well, so
yes.
that's why the shades.
Yeah. Yeah. In fact, very interesting. Recently met a chap here in London, Mandeep Sagu, who's an ophthalmic oncologist who's one of the foremost experts on retinal melanoma. Lovely, lovely chap who educated me about that particular condition. So, likewise, lung cancer. Tell us about efforts to reduce smoking in Australia. We know that's obviously one of the primary causes, and you serve on the Australian Lung Cancer Trial Group. What's happening in this space to help patients with this diagnosis, which killed my father?
Lung cancer obviously is the one is a subspecialty where I trained up at Guy's Hospital in my lung cancer days, where I did a clinical fellowship up at the Guy's Hospital. So, in terms of the public health campaigns, I think there's been a lot of public awareness. People are aware of the smoking. Unfortunately, that's just been sidetracked by how the smoking has gone down, and people have awareness, and the government's initiatives such as that increasing the cost prices for the cigarette, making sure that there is packaging, making sure there are signs up on the packet to say, look, how the smoking can affect you. But lately, this has just been affected by vaping and using the other products which has come through the markets. So that's not really helped the cause. So we were coming at a point a few years ago where we said, oh, there's the public health campaign seems to be moving away, where it's actually working, and we're starting to see a slight shift in the lung cancer incidence. But unfortunately, with all the vaping and all the other products which are available, and also now you've got other occupational diseases which has come across uh, as part of the such as the stones and uh, all the occupational health hazard. You're starting to see a different kind of a cancer. So we moved away from the smoking related cancer to something which is more occupational, more which is because of the other thing like vaping. So we're not seeing a more central kind of a cancer. We're starting to see more cancers which are more towards the periphery of the lung, which basically means more surgery, more radiotherapy choices. Overall, the lung cancer has been, I mean, it's not as doom as gloom because there's been more treatment. Since in the last 10 years, the immunotherapy has made a big difference. We've got more targeted therapy, we've got more research, more combination. So we can treat our lung cancer patients a lot better. 5 10 years ago we used to only be able to have the chemotherapies. Now we can treat these people, and the concept of personalized care or personalized medicine is probably much more relevant in lung cancer than any other cancer in this space.
And moving on to prostate cancer, I recently saw some data on um, actinium labeled radiopharmaceuticals in prostate cancer. I believe it was in castration resistant metastatic prostate cancer. What promise do the radiopharmaceuticals hold? I know that you work as a medical oncologist, but it's normally a team, a multidisciplinary team. So, yeah, what's the state of play for prostate cancer? What's new and great?
I mean, as we all know, the prostate cancer people, prostate cancer patients have a bone predominant disease. So radioactive pharmaceutical basically helps them. So you're giving a radioactive which is particularly attached to a molecule so that it can just attach to the prostate cancer cells anywhere in the body. So it gives us a much more better options for treating the bony only disease rather than giving them the chemotherapies. And that is starting to show, and there's lots of compounds in the market which are basically starting to show that they can actually make people live longer as well. These are the bony only disease, uh, not for people who got other disease such as the lymph nodes and the organ disease, but it's predominantly a bony only disease, which forms a major chunk of the disease. This is basically has made quite a bit of difference. We do. Uh, the only caveat at the moment is because it is not readily accessible in the countryside of Australia. Obviously, if you look in the rural and the regional, then the chances of access and travel is harder. Obviously, people who got much closer to the metropolitan have got a better options of doing it. It is getting better. It is definitely, people are seeking more, and there are a lot more options available. But that's the kind of things which will completely change the prostate cancer in the years to come.
Yeah. So I think we all know each country has got its own medical systems with strengths and weaknesses. And you've got experience in India, the UK, Ireland, Australia. And I know that you're involved with international oncology organizations. So, how do you feel that your global involvement shaped your view of cancer treatment, research, and access? And here's a way to phrase it: if you were recruiting a young oncologist and wanted him or her to move to Australia, how would you sell them on why it is a great place to practice oncology and why?
Look, the biggest sell point is because I've actually done it. I've actually came from UK to Australia, went back to UK, came back to Australia, and been involved with a lot of different organizations and understand a lot of healthcare systems. And I think the one of the biggest advantages of the Australian health system, because like NHS, it is actually a public healthcare system. So it's a health equity for all, which gives you that anybody walking tomorrow, you can actually be comfortably provide them an evidence-based care without having to worry about the financial burdens, insurance status and stuff. Yes, the private health insurance is there, but in a public health system, it is one of those system like NHS, which gives people evidence-based compassionate care. So I think that would be one of my strongest selling points for anybody to working in Australia.
Okay. And opportunities for research are good. And
We have got universities. I work as a clinical lead with one of the Monash University, and then I think the chances for collaboration, the number of researchers, number of research centers, the opportunities to have a career opportunities, to have a different choice. Like I've actually done from a I came from a Indian background to UK and Australia, and I've done a lot of clinical research, academic research. So it just gives you the opportunities, and now I'm doing the administration. So it's just not, so you can actually showcase that you're just not limited to what you do. You can actually have got different pathways to do. Some people take on a lot of lab research at the later end of their career. Some people take a clinical research. Some people take more teaching kind of an approach. Some people have more of a private practice. So Australia kind of offers them a different aspects. And now with the international organization, there is a chance of research, collaboration, multi trials. So there's a lot of choices these days as a clinician.
so Divi, you can't open a newspaper today or turn on the television without hearing about artificial intelligence. I've seen some utilization of AI in oncology, such as using it to interpret scans or define who should or shouldn't get certain therapies, expensive therapies. What are the areas of the deployment of AI that particularly excite you?
I think you've named a couple of things, and I think that's going to be the biggest areas, which is going to be the better diagnostics. It's going to be the better picking up a scan, the better screening, the screening procedures. Because at this stage, the way we are going, we just can't control the cancer incidence. But what we have a chance with the AI is to go at an earlier stage, identify more cancers, earlier stage, treat them, and have more better radio diagnostic scans so that we can be not missing out on the cancer. So we're treating less late stage cancer, but treating more early stage cancers, better diagnostic, better robotics, so that basically less morbidity, patients can have complicated surgery with less mortality, morbidity, etc. And also the other issues about what we really struggle is with a lot of cancers. Patient wants to know, doc, what's my 5 year risk? I want to plan somebody, what's kind of risk at the age of 70s if I'm diagnosed with the cancer today, what's my risk that I'll be still be around in 5 years, 10 years time. So those complicated algorithms which were just available predominantly for the breast cancer, which is based on years of experience, but to able to do that for prostate cancer, able to do for the other cancers, that's where I think the AI in predicting your risk before surgery, after surgery, before chemotherapy, after first, second, third, fourth lines of treatment will just help. And obviously, the cost of healthcare is going up. Like most health economies do struggle these days. For us to predict cost effectiveness, and that's where the trials are starting to work towards, because government is going to look at costing. Yes, how many people are you going to treat? What's going to be the cost impact? Those kind of a thing, the AI is going to make a huge difference in years to come. From health economics will be the breaking point.
Yeah, absolutely. And obviously, an aging population and a growing population. So, finally, a question I like to ask everyone I'm privileged to chat with. If a magic genie appeared and granted you three wishes for the future of your area of healthcare, what might those wishes be?
uh I think the first, I believe in health equity, so I think uh I would like to have one of my wishes is that everybody gets the access. My passion is health equity because I come from a developing nations, and I just believe that everybody should have the same access. So everybody should have the same degree of clinical research, and should not be based on where they live, where they were grown. And this comes from my own personal in my early years of life. Second would be that we providing the older people, we do not tend to take older people as a separate individual. These are the people who who have seen the life, and they have still got a lot to offer to the society. So the doctors should just consider them as as any normal person, and not consider them, the old adults, are a separate species. That would be my second wish. And third wish is obviously we make sensible approaches. We just obviously, on the other flip side of it, we just work to make sure that we provide a compassionate patient-centered care. And as an oncologist, we should be involved in the care of the patients, even if they don't have if even if they don't wish to have our next generation treatment. So I think having a compassionate, patient focused care, health equity, and making sure global oncology is not just the country based oncology would be my three wishes.
Oh, good on you. Well, I'm afraid that that's all that we've got time for today. And I'd like to thank you for being with us on this, the very first episode of Onc Now. A real pleasure to meet and chat with you, Dr. Divyanshu Dua. Thank you so much.
Thank you so much. Thanks for the opportunity.
So, folks, thanks for listening to this episode of Onc Now. If you've enjoyed listening, and I suppose if you're watching this, you must have, please subscribe on Spotify or Apple Podcasts or wherever you get your podcasts so that you never miss an episode. Until next time, I'm Jonathan Sakia, I thank you for listening. Please, everyone, stay safe, stay well, stay curious. Bye for now.